Hi everyone, welcome and thank you for joining us today as we talk about blending KPIs to assess practice wellness. My name is Scott Everett. I'm the Vice President of Healthcare Solutions with Practical Data Solutions, and I'm joined today by Russell Hendrickson, our CEO. Welcome, Russell.
Thanks, Scott, and it's great to be here. Before we begin, I'd like to spend a minute about who Practical Data Solutions is. We specialize in healthcare visualizations, analytics, data warehousing, and data staging for healthcare organizations. And we bring more than 21 years of proven experience helping organizations. And if you look at a little summary of what we do, the very last bullet on our screen here is through blending data, PDS drives organizations to performance goals. And that really is what we're going to be talking about today, which is blending metrics to assess practice wellness. And so before we jump into that topic directly, I wanted to talk a little bit about analytical intensity. And if you've attended any of our webinars or you're familiar with PDS, you've heard me talk about this as part of your analytics strategy. And so as you think about lower levels of analytics intensity, most organizations, when they start with analytics, they are summarizing data or they're providing charts and trends, most of your reporting. And healthcare organizations are very good at doing these things. They're sort of the lower levels of analytical maturity. Where we get into harder levels of using analytics and applying analytics to the practice of healthcare, we have a sort of a bigger leap to benchmarking or building relationships between data. And that's what we really mean by blending data. And ultimately, when we build relationships, then we can even start to project performance improvements or look for ROI. So that's what we're going to be talking about today. Let's go ahead and take a quick look at an example of a visualization where data has been blended. Scott, do you want to walk us through this a little bit?
Yeah, when we talk about blending data, sometimes people just kind of think that it's just about putting a bunch of metrics on a page and looking at it. And, obviously that's something that can be done fairly simply where you can take data from, the revenue cycle system and look at charges and payments and payer mix and maybe even blend in some data from the appointment scheduling system and look at that and even maybe bring in patient satisfaction as well. And that's all well and good. You can even sometimes look at multiple systems at one time and see how that's impacting things. But at the end of the day, if we want to assess practice wellness, it's really all about not just looking at these metrics at one time, but how they correlate one with another and how we can really use that to assess the overall health of our practice. So what do we mean when we talk about practice wellness? It really means a lot more than just looking at, the financial stability or quality that we're providing or even how satisfied our patients are with it. What we're really trying to do is gauge the overall health, not just now, not just symptomatic, but what is it that needs to be treated and how can we look not just today, but down the road as well.
So the MGMA outlined factors leading to better performance in medical practices back in a survey they did in 2017. And so for better performance, they looked at things like higher revenues while controlling operating expenses, including IT expenditures. Their third bullet, greater physician productivity, that's kind of at the heart of practice wellness. And we're going to talk about that, patients using their patient portal. And then their last sort of summary item was patient scheduling, faster scheduling, availability, sort of minimizing no-shows and cancellations. So, some good performance ideas here for performance, but how does that relate to practice wellness, Scott?
Yeah, so I said before when we consider practice wellness, it's a little bit more than just looking at one of these factors at a time, and it's more than just looking at, patient access, scheduling, productivity. It's how do we balance all of those at one time? Obviously, the key of any healthcare organization is going to be their patient quality and the clinical quality that they're providing to their patients. But if you really look at it, it's really difficult to do that without being a financially stable institution as well. Your physicians have to be productive, your employees have to be engaged. All of that helps bring about that clinical quality. And so really you have to find that balance and looking at how you can incorporate all of these things in order to provide the best possible care for our patients to make us the best and most stable organization that we can be.
So how do we go about actually measuring practice wellness? How do we go from data, reports, dimensions within a database to understanding and converting into that something that's meaningful? And so there's two sort of key ideas that we talk about here at PDS as a data analytics company. And the first one is joining data. And we think about joining data as joining data from within the same application. So where we have a common set of dictionaries. So charges and patients and payments and denials and AR and coding patterns, typically come from the same data set. So we're really joining different data sets. And, that requires a certain skill level. But to go further, when we think about blending data, we equate blending data to having different data sources, patient satisfaction data, with clinical or quality data, with data coming back from the payer, with expense data, and then joining that up with, potentially even facility data or hospital data. So blending data, taking things a little further from a modeling and an IT side, it's a much more complex skill set. So how we're going to relate all this to the topic today, which is blending metrics, and we're going to talk about to tell the whole story. And so we've put together what we consider sort of top 5, and I'll call them top 5 sets of metrics that we like to blend. And we're going to kind of share and use this to illustrate why blending metrics and blending different data sets really helps you understand, the whole picture when it comes to your practice. So let's go ahead and look at the first one that we've queued up here, and that's, if we just look, let's say, at billed charges. Billed charges are up, we're doing good. Maybe we did some trend analysis. Things are moving in the right direction. We're doing great, right, Scott? Billed charges.
Well, and billed charges is absolutely something we want to see increasing month over month, year over year, as we go forward to be a healthy practice that we want to be. But at the same time, there are other factors that we need to look at there. Obviously, we need to take those billed charges and turn them into workable cash at some point. And those can get tied up at different places in the revenue cycle, whether it's the physicians not turning their charges in, whether it's sitting in some sort of front-end editing system while we clean them up, or making sure that we're managing the AR on the back end. The billed charges is nice. Seeing that volume is good, but we have to turn that into cash. And that's, a good example of there are other things to consider rather than just that one singular metric.
So let's take another example now, and we'll dig a little deeper. So appointments are up, right? Appointments mean patients are coming through. That means we should have charges. We're doing good, right, Scott? Appointment volume's up.
Again, appointment volume is absolutely necessary to be a stable and healthy medical practice. We need to be able to see that increase in patient volume, and we need to be seeing new patients and more patients across a broader spectrum. But a lot of times, if you look at that just in and of itself, you're not seeing that when you try to sometimes force just a large number of appointments with the same level of capacity that you have in the same level of finite time, then it can cause some things like physician dissatisfaction while they're working 10 to 12-hour days to keep up, or patients waiting a long time to be able to get an appointment, or even when they do get an appointment, if they're spending a lot of time waiting to be seen in the waiting room or the exam room, then that's going to cause some dissatisfaction. And so while that trend of appointments may be good initially, these indications could be that that upward trend could turn into a downward trend fairly quickly if we don't correct these other problems as well.
Yeah. So let's go ahead and look at a visual dashboard where we blended some of those metrics together. So we talked about, focusing on appointment volumes and certainly, being able to understand where our volumes are and where they're trending. But as Scott just shared, we also want to be very careful of looking at utilization and making sure that our physicians maybe aren't double booked, overbooked, working a lot of overtime. Some of the other key metrics we talked about is, how long are patients waiting to be seen from the time they actually check in to when they're actually in front of the physician receiving care. And then, of course, how long does it take when a patient says, well, I want to be seen, from the time they call in to when they can actually get an appointment and that day comes. Is it a couple days, or it could be a couple weeks? So this is an example where we're really joining different data sets from within the patient access application. We start to tell, the rest of the story here. Let's go ahead and look at a third area. So we have a great payer contract. It's 155% of Medicare. I don't know that too many people could be happier, right? Look at that revenue.
And payer contracting, that would be great if we could get our contracts to look that way, and that's a good negotiation set. But once again, we have to consider the fact that the fees that we negotiate on the front end have to be worked on the back end. And while we may get good rate from the payers themselves, there may be a high co-insurance or a high deductible on the patient side that we have to collect, or denials can come in to play as well that really make things look a lot different from a total reimbursement standpoint than we really are. So let's take a look at this and see if we can help to kind of paint the picture a little bit better. And so when you look at payer contracting, again, what we like to talk about are the rates. What are the fee schedules that we're getting? What's our percentage of Medicare? What's our RVU conversion factor? Are we getting paid from a timeliness standpoint of getting the bills out and getting payments back in? And are there any quality incentives involved, which is good. But again, we have to work that on the back end. And so we have other things to consider, like those patient collections that we talked about. We have to look at denial rates, and of those denials that we get, what are we actually recovering? When we factor all of that in and look at the time that it takes and the amount of effort that we have to put in to actually work with this payer, if we blend this data together, it may tell a very different story. So what you can see here is each one of those separately looks a little bit different. When you bring them together, that's when you can see here's what your actual collection rate is when you factor in all of the denial rates and things like that we may have contracted for 155% of Medicare, but we're only collecting 130, et cetera.
So let's go ahead and take a look at a visualization. This one is a little more complex here. We're looking at denied charges by division. We're categorizing our different payers. We're even looking at denials by payer in a scattergram here. But where I want to focus you is this middle chart here. And what we're looking at is the contracted profile amount based on the volume of services. So this is actually how many services we're performing. And then on the bottom, on the axis here, we're looking at the recovery rate. And so what we're seeing is these high volume procedures that have very low, below than 10% recovery rate, this is actually showing us, where we have, potentially a lot of losses or at risk. And then if we look down at the bottom here, you'll actually see here's the procedure. Here we're then blending the contract amount along with the volume of services. And over here on the right in red, it jumps right out at you that you can see this is either lost revenue. If we were to flip the switch here and say it's fully adjudicated, right? That would have been lost revenue by procedure. So we can very quickly start to identify where and even look at which payers we're losing. Or we could flip it to what's sitting in the open AR. It's not fully adjudicated, and these are at-risk dollars that if we can't find a way to raise these recovery rates, we're going to be losing that opportunity. So a really good example of blending data and really understanding what's going on with that great contract that you may not be able to realize that revenue.
Yeah, and as you look at this dashboard as well, you can see that a lot of these denials were sourced basically as payer-sourced denials, meaning it's probably non-covered services or bundled services that are kind of outside of the norm. And when you look at that has to be factored into your overall reimbursement as well. Not to mention, how is it that these denials may have impact on any sort of quality incentives that you may have, or what sorts of patient populations and care issues that these payers may be scoring on their end as well. And that actually kind of brings us to the next one that we want to look at, and that's HCC risk scoring. We really want to get into a little bit of the quality, and when we talk about quality, we want to look a lot at how is it that we are treating the chronic conditions of the patients that we're seeing. So the HCC scores, you can blend those in with, is really just getting a hold of your population and really understanding those. We want to know who are our patients, how many patients do we have, what are the conditions that they're being treated for that we may have, that may be chronic conditions that we need to see, and are we getting their required visits in? When we look at that, we probably want to look at the well care that we're providing for them. Are we getting these patients in for their physicals or their Medicare wellness visits? Are we able to score those chronic conditions and able to calculate risk scores upon those? Are we meeting the quality measures that we've agreed to with our payers, et cetera? And then, of course, once we've identified these chronic conditions, how are we doing in treating them? Are we maintaining a good continuity of care? Are we communicating with the specialists that we may be referring them out to? Are our patients in compliance with whatever treatment plans that are out there. So again, you can see we have 3 different systems, 3 different areas that we're working on, but when you blend them all together, it really gives us a much better picture of the whole, of how it is that we're doing as far as these individual HCC visits that we're getting in, whether it's a wellness visit or a treatment plan visit that we can monitor with these patients. Blending this data helps to see how they all correlate together to tell how we're doing.
So let's go ahead and take a look at a visualization here. This one is a little different than some of the ones that we've looked at, but over here on the left, we can see our providers, and the providers are actually being counted by patients with chronic conditions. We can also quickly see who are our high risk or moderate risk patients versus our lower risk patients. And we can then over here on the right side, we can actually see down to the patient level in the detail, as well as what are the HCC categories that that patient has. And so where we're blending data here to sort of tell the whole story is, first off, we can see which care teams or which physicians may have patients, but we're then blending that with the utilization of the physician. Has this patient been in for an annual wellness visit, or are they past due? And so by simply clicking on past due, and then we want to see, well, does the patient have an upcoming appointment? And if they have no appointment, we can quickly start to see how many patients, which patients are either, not even in the schedule, and then focus our care teams on being able to provide better care. So makes it very easy when we blend the data, 1, to understand our population and where there's a gap, but then 2, where do we need to focus?
Yeah, and this is all really good as far as maintaining that same quality of care that our patients need. But I think if you blend in another data set, that it really helps to look in our organization and get kind of our house in order as well. If you attach kind of financial incentives that are available out there as well, a lot of these key initiatives, if you were looking at Medicare wellness visits and physical, a lot of times those reimburse at a higher rate than standard office visits. And so what you can see here is there are opportunities, there's a financial opportunity for providing the right care, for doing the right thing. And what's important to understand when we're doing this and providing this is it's a very compelling reason to make the change. It's a very compelling reason to take on these initiatives. And really, when you think about it, doing the right thing is going to make us a more financially stable organization, which is what's going to allow us to provide better care for our patients.
Yeah, it's certainly very cyclical, right? Better care, happens to lead to more revenue, but additional revenue allows us to provide better care. So let's go ahead now.
Funny how that works.
Yeah. Let's go ahead and take a look at our 5th example. And this one, we're really going to kind of build on everything that we've just shared. So we're going to talk about blending physician productivity, patient access, patient satisfaction, and sort of all of those key factors, kind of tying back to practice wellness, but as an example here. And so we're going to look at a number of different factors. Scott, why don't you walk us through the Venn diagram here to try to understand what are the metrics and how do we look for where the sort of the key overlaps are?
Yeah, when we're talking about the overall wellness of our practice, physician productivity is really going to be at the core of that, because it's what's really going to lead to all of the other factors coming into play. And obviously, there's a lot of things that lead into physician productivity, the biggest one of which is going to be number of appointments that they have, number of patients that they see. Obviously, you can look at things like coding patterns. You can look at procedures versus office visits. You can look at, a number of different things that way. But the patient access is going to be the biggest driver of that productivity. And when we're looking at patient access, we're looking at things like schedule utilization, how fast can we get patients in, no-show cancellation rates, et cetera. And then what's the satisfaction level of our patients that we are seeing? Because that's what's going to help us maintain that upward trend, particularly when we're looking at, would you recommend this provider, or would you recommend this group? That's how we're going to see overall growth in patient level, both at the provider level as well as at the practice level. And so again, all 3 of these things definitely come into play. It looks like a lot to manage, but again, you bring it all back in together. When you blend this data, you can see the correlations between all of them. And really, you're going to see that the primary driver of that is going to be the patient productivity, the number of patients that we're bringing in. And that's where we need to focus our efforts on making sure that they're satisfied and that they can get in quickly. And we need to work around all of that in order to maintain our highest levels of productivity.
And so we had a little fun building out this example here. And there's a lot of different data sets we're going to share, but we built out this example of blending data iteratively so you could kind of see the thinking and the thought process behind bringing in data sets. And what's kind of fun about this is as we show it to you, I think you'll start to see as we blend different data sets, it starts telling a different story and helping round out the picture. So the first panel in our web dashboard here has just divisional charges, so we can easily click and identify, which providers are contributing and where the charges sit. We also then have the divisional RVUs, so we can start to see who's producing the most RVUs. We've also then taken and brought in the physicians and we benchmarked them, and we've built, some sort of static benchmarks at 200 and 400 RVUs, average RVUs per month. Over here in the right panel, you can see the charges, the work RVUs, and then the clinical FTE. Now, in a production setting, you'd want to adjust clinical FTE, especially if we're going to do comparative between physicians. We want to make sure we're measuring everybody appropriately if they aren't full-time. So that's our first panel. Now, what we're going to do when we start thinking about RVUs, there's sort of two key billing metrics that impact on RVUs. So in the second panel, we've now added in level 4 coding. Instead of trying to show all 5 E&M codes in a chart or a graph like most organizations do back to the physician, we're just focusing on level 4 coding, with the idea that we know what ranges physicians should be coding level 4s in on average. And so we can start to do comparative marks and see where the physicians are coding against each other, especially in like specialties. In addition, we can also look and see, potentially even if there were physicians that are coding maybe higher than they should be, that might be over contributing to RVUs. And we've then tiered the coding into sort of 4 categories. So we could sort of find where best practice might be this level 3. This is going to come into play as we keep blending more metrics by using these little thermometers that tier the different metrics. The second metric we brought in from the billing and we've joined up is, charge lag. How quickly are the physicians turning in and getting their charges complete so they can be billed? And so again, we can start to see very quickly that there might even be some opportunities with some of our top performing physicians to improve their performance. You might say, well, we're only focused on the bottom. No, we could look at the top physicians as well. So in this case, we brought in those 2 metrics. And we've also then consolidated into these little sort of tiered thermometers that we're going to show as we go. Scott, we're going to bring in another data set. Why don't you walk us through what we just added here?
Yeah, so obviously we can look at the, the coding and the, bringing in the RVUs so that we can see initial productivity. But at the end of the day, we need to make sure we're getting patients in to be seen. And there's a couple of factors that are really the top key. One is the overall appointment count, and the other part is looking at the percentage of the schedule that has been booked. So when you're looking and talking about correlation, sometimes you're talking about, well, there are providers with low appointment counts, but their schedule is fully utilized. Well, that's a good thing to look at because the practice can then really help the provider, and that's usually a system issue. And so they can help them to more appropriately template the time that they're working. They can help them to look at their appointment durations and things like that to help them really schedule in a more optimized fashion and make sure that the system is really reflective of the work that they actually are capable of being able to do. In addition to that, if you're seeing lower levels of scheduling and low appointment levels of scheduling and low appointment counts, you can also look at that and say, okay, maybe we need to improve outreach for this particular provider. We need to look at more referral opportunities, or we may need to look at more marketing opportunities. But each different problem has kind of a different solution on that. So looking at those correlations is really key in making sure that we can optimize that.
Excellent. So again, you'll notice we've converted the utilization into this little tiered thermometer here, and we're going to add and blend in yet another data set. So now we're really starting to get a much better picture of what's going on. In this case, we've now added in the patient satisfaction metric ease of scheduling and the patient satisfaction would recommend, right? So again, just because we have good producing physicians, we want to really think about practice wellness. And so here we might want to look, if I look at some of our top producing RVU physicians, I can quickly see, for example, that, Karen Davis is performing very high, but her, marks for would recommend, and maybe she's got a very limited panel, aren't very good, as well as, as Scott was mentioning, we're looking for performance opportunities. We certainly want to make sure physicians, as they're either learning or adjusting, or maybe, trying to perform, they may not be as focused on the patient as they are on some of the other things. So this really now rounds out, and we've got now patient sat with appointments, with our sort of coding and core revenue cycle metrics here. And then we've got one more metric we're going to blend in as this example. Obviously, we could keep going with this, but Scott, walk us through what this last metric is and why it's important.
Yeah, so I think the last metric that we're bringing in and looking at here is in years of service. And I'll go through and talk about this a little bit. You can see the way this is set up with the years of service correlated with the work RVUs in the productivity in that first chart there. And what that really helps us do is we're providing two different metrics on a graph so that we can look at quadrants, and we can see the lower tier providers that are there, and we can say, okay, these are providers who aren't necessarily performing at a high RVU level, but they haven't been in the practice very long. So we can help those ones who are initially in the practice kind of optimize while they're still building up their panel a little bit. We can help them with their coding by providing some audits and things like that. We can help them with their charge lag by giving them some training on how to get their notes signed off and into the system a little bit more quickly. But then if you look at the other quadrant, which is right above that, we can work a little bit with providers on helping them get their practices built up. We can help them with their scheduling. We can help them with their coding and their charge lag. But what happens when they've been in this practice for 10, 12, 15 years? How much more can we continue to train them and have them perform at this level of productivity? I think at some point you have to say there's only so much the practice can do, and then just kind of question what are some other alternatives that may be available for physicians who just can continue to perform at these lower levels despite having the practice do everything they can to help them get up to the level we need to see them in.
And obviously, we could continue to round out this picture and blend in other metrics. One of the key design techniques that I do want to share for this is that if you notice, by switching to these sort of tiered performance for some of the different metrics that we were blending, as well as then representing in a two-dimensional appointment count and utilization, it made it very easy to sort of identify years of service against RVUs or high volume or low volume, right, to look for those outliers, which is really what we're trying to do, is understand the performance and the opportunities to improve. If we go back to where we talked about analytical intensity and why are we blending data, and so if we look again at this chart here, we've moved beyond trending and benchmarking. We're looking at the different relationships that all impact, physicians' performance, and then, as Scott pointed out, even bringing in their years of service, which might indicate a different outcome as to what we try to do to improve their performance. But what's interesting, and we try to represent this in this visual here, moving and doing correlative analysis is a fairly big analytical leap if you don't have a strong set of analytics and a strong team. But when we start thinking about projecting or calculating the performance gains, it's really quite easy when we know and have already built out the relationships as well as brought in our benchmarks. So as we were building out this visualization, we added one more page to it, which was to look at the performance opportunity, and we actually wanted to quantify the potential improvement, kind of in an ideal world. So as we were building this out, we thought, let's add what is the performance improvement, and quite simply, we did a fairly simple estimate that said if the physician is performing, less than an average of 400 RVUs on average per month, we'll just net out what if they moved to 400 RVUs, and what if their reimbursement then was at the current Medicare rate. And so you'll see right here on the right side, we can quickly start to see if we can move some of these bottom performers up. What's the potential opportunity by physician or to the organization, to the practice, or to the division that we're looking at? So fairly easy to calculate. We also then said, what if we just took every physician and we just tried to focus everybody on proving 10%? Where might we see some additional gains? So a couple easy ways to quantify ROI. And in doing so, really adds to the fact that when you think about trying to improve performance, maybe we need to hire some external trainers, or we need to set up some times to pull the physicians out of clinic, right? What we're really thinking about is, well, what's the cost of improving performance? Well, it really helps if we can net out the gains. In addition, as we're doing our performance efforts, if we have a target to measure against, then that also allows us to better, justify the time, the efforts, the resources that we've applied to improve performance, because we can actually measure and quantify the outcomes.
Yeah, and like I said before, those returns on investment can be very compelling reasons behind any sort of change initiatives that we need to put into place here. And that's really what we're going for. Is if we're trying to improve the health of our organization, the diagnosis isn't enough. We have to have a treatment plan in place, and we have to be able to work that treatment plan, and that's a way to get people to buy in with that. Now, we've just given kind of a handful of examples that are out there, and obviously one of the things that makes healthcare analytics kind of tricky is that there are just so many data sets that are possible to look at. But we just kind of wanted to talk a little bit about how to be able to see these correlations. And so if you're already doing things like this, some other examples that you could look at are obviously things like bringing in revenue and expenses and making sure that not just your revenues are in play, but your expenses are appropriate for the amount of growth that you're seeing as well. Or you can look at things like if you're having issues with patient access, but it's not necessarily utilization related, maybe you want to bring in some call center metrics to look at how some things there may impact patient satisfaction or things like that. Additionally, probably the biggest thing you can bring in once you get up to your highest levels is quality metrics. You may want to be able to bring in and correlate patient vitals, patient prescriptions, and drugs that are being utilized, looking at things like, A1C scores for your diabetic population. All of these are, opportunities to bring in and look and correlate to make sure that you're not just focusing on one place, but that you're looking at the system as a whole and make sure that you're treating the whole problem that may be out there. So if we want to talk about some key takeaways from the presentation today, it's really that practice wellness is all about balance. We can't just focus on the business side, and we can't just focus on the patient care side. We have to be able to do both of them. Patient care is going to make us a stronger practice, which will allow us to provide better patient care. We need to maintain that balance in everything that we're doing. And we want to make sure that we have all of the insight that's out there. We want to make sure that we're looking at correlations and maybe how an increase in one can cause a decrease in other, how we look at productivity and make sure that it's not causing a problem with patient satisfaction by trying to, just get these patients in and out and in and out and in and out if they don't feel that they're getting the care that they need. And again, focusing on just one single measure at a time may just really put, kind of a cloud on the bigger picture of everything that you're trying to see.
And the pun was intended there, wasn't it, Scott?
Always.
Always. So some of the other things to consider, by blending data and bringing in benchmarks, it makes it much easier to quantify performance gains, performance opportunities, and even the ROI. So it makes it very easy to justify why are we doing this, where are there performance gains, as well as focusing your efforts, right? So that you're really focusing on the 20% that'll yield 80% of the results. And then, of course, leveraging analytics can help you manage today's challenges, while providing insight into tomorrow's strategy. And I think this was one of the big lessons that I think came out of COVID in particular was COVID forced practices in healthcare to really think about patient access and treating patient quality in a different way. A lot of changes came with telemedicine. And so by having sort of the techniques and the tools to be able to blend data when things change dramatically, it's really important that you have a strong tool set that allows you to be able to analyze and understand the changes and how those impact not just a single data point, but how it correlates to your overall strategy for your organization.
Okay. Thanks, everyone.
Thank you. Have a wonderful day.